Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about chronic lymphocytic leukemia, CLL, the most common type of leukemia in Western countries and in adults. Definition, epidemiology, pathophysiology, clinical features, and laboratory findings of CLL are discussed in this video. Chronic lymphocytic leukemia is defined as a low-grade lymphoproliferative neoplasm with more than 5,000 per microliter clonal B cells in the peripheral circulation expressing CD5, CD19, CD20, and CD23. Chronic lymphocytic leukemia, small lymphocytic lymphoma, is an indolent malignancy characterized by the monoclonal proliferation and accumulation of mature but immunologically dysfunctional CD5-positive B cells within the blood, bone marrow, and secondary lymphoid organs. The WHO 2022 classification continues to consider CLL and SLL a single entity with different clinical presentations. CLL presents mostly in peripheral blood and bone marrow. SLL primarily involves lymph nodes and other lymphoid organs. The exact etiology of CLL is unknown. Genetic factors, rather than environmental factors, are the most likely cause of CLL. However, few known risk factors for CLL include occupational causes by exposure to certain chemicals, radiation exposure, and tobacco users. Tobacco users and cigarette smokers show a significantly elevated risk of CLL compared to non-tobacco users. CLL is the most common type of leukemia in Western countries, accounting for about 22 to 30% of all leukemias worldwide. The annual incidence of CLL varies by geographic location, race, age, and gender of the population. Global annual incidence ranges from less than 1 to 5.5 per 100,000 people, and males are more commonly affected than females. CLL is a disease predominantly of the older age group as the median age at initial diagnosis is 70 years. CLL can affect adults as young as 30 years of age and is extremely rare in children. CLL is reported to have a genetic basis and is known to run in families. The age at diagnosis of the second-generation offspring is nearly 20 years younger as compared to the parent. First-degree relatives, siblings, children, or parents of CLL patients have double the risk for CLL. The capacity to generate clonal B cells seems to be acquired at the hematopoietic stem cell stage, suggesting that the primary leukemogenic event in CLL might involve multipotent, self-renewing hematopoietic stem cells. The cellular origin of CLL is still debated, but it is assumed that CLL cells originate either from CD5-positive CD27-positive post-germinal center B cell subsets or unmutated mature CD5-positive B cells. The pathogenesis of CLL is a two-step process that leads to the clonal replication of malignant B lymphocytes. The first step is the development of MBL cells secondary to multiple factors such as antigenic stimulation, genetic mutations, and cytogenetic abnormalities. The second step is the progression of MBL to CLL by the further insult to the B-cell clone, either due to additional genetic abnormalities or changes in the bone marrow microenvironment. CLL is subclassified into cases expressing a mutated B-cell receptor, MCLL, and a more aggressive subtype with an unmutated B-cell receptor, UMCLL. It has suggested that UMCLL originates from naive CD5-positive B cells regularly present in healthy humans. Rare memory CD5-positive CD27-positive B cells have been proposed as the cell of origin of MCLL. Approximately 80% of all patients with CLL carry at least one of these common chromosomal alterations, a deletion in chromosome 13, 11, 17, 6, or trisomy 12. Cytogenetic and molecular genetic abnormalities most characteristic of CLL are summarized in the table. Deletion of the long arm of chromosome 13 is the most common chromosomal alteration occurring in approximately 50% of all cases. An isolated deletion of 13q is characterized by a benign course of the disease and good prognosis. The microRNAs 15A and 16-1 are located in the critical region of 13q deletion and regulate the expression of proteins that can inhibit apoptosis or that are involved in cell cycle progression. Deletions of the long arm of chromosome 11 can be found in approximately 25% of chemotherapy-naive patients with advanced disease stages, and 10% of patients with early-stage disease. These deletions frequently encompass band 11q23, harboring the gene ataxia-telangiectasia mutated, which encodes for the proximal DNA damage response kinase, ATM. In addition, patients carrying a deletion of 11q clone typically show a bulky lymphadenopathy, rapid progression, and reduced overall survival. Trisomy 12 is observed in 10 to 20% of patients with CLL and is associated with an intermediate prognosis, but relatively little is known about its pathophysiology. CLL cases with trisomy 12 often demonstrate atypical morphological and immunophenotypic features and a higher incidence of thrombocytopenia, Richter transformation, and other secondary cancers. Deletions of the short arm of chromosome 17 are found in 5 to 8% of chemotherapy-naive patients. These deletions almost always include band 17p13, where the prominent tumor suppressor gene TP53 is located. Patients with CLL carrying a 17p deletion clone show marked resistance against genotoxic chemotherapies. Deletion of 17p is predictive of a short median survival time and a poor response to chemotherapy. Among cases with confirmed 17p deletion, the majority shows mutations in the remaining TP53 allele. In cases without 17p deletion, TP53 mutations are much rarer, but have a similarly detrimental effect on chemotherapy response and overall survival. The deletions of the long arm of chromosome 6 are non-random cytogenetic anomalies found in 3 to 7% of CLL cases. The 6q deletion anomaly is characterized with atypical lymphocyte morphology, CD38 positivity, more extensive lymphadenopathy, and intermediate incidence of immunoglobulin heavy chain gene variable region somatic hypermutation. It has been suggested that CLL with 6q deletion comprise an intermediate risk group and is predictive of shorter survival. In cases with 6q deletions have also been found significantly lower hemoglobin concentration and significantly higher mean age, percent of peripheral prolymphocytes and level of serum lactate dehydrogenase compared with patients without 6q deletion. Patients with CLL are often asymptomatic at the initial presentation, when a routine CBC reveals abnormal lymphocytosis, leading to CLL diagnosis. Approximately 5 to 10% of CLL patients are symptomatic with symptoms such as fever with no evidence of infection, unintentional weight loss over the last 6 months, night sweats with no evidence of infection, and significant fatigue. Upon physical examination, 50 to 90% of the CLL patients present with lymphadenopathy. The most common sites include cervical, supraclavicular, and axillary lymph nodes. On palpation, the nodes are firm, non-tender, round, and freely mobile. Splenomegaly is the second most commonly enlarged lymphoid organ, seen in 25 to 55% of cases. On palpation, it is painless on non-tender with a smooth and firm surface. Hepatomegaly is seen in 15 to 25% of cases. The liver is mildly enlarged and palpated 2 to 6 centimeters below the right costal margin. On palpation, the liver is firm and non-tender with a smooth surface. Two staging systems are used in CLL patients, RI and BINET. The RI system is based on lymphocytosis, hepatomegaly, and splenomegaly with or without lymphadenopathy and hemoglobin and platelet levels. It is more commonly used in the US. The BINET staging system stratifies patients based on the number of involved lymphoid sites, the level of hemoglobin and platelets, and is more commonly used in the UK and Europe. The 2022 fifth edition of the WHO classification requires a minimum of at least 5,000 per microliter clonal B cells with characteristic cytological and immunophenotypic features, maintained for at least 3 months. The presence of cytopenia caused by a typical bone marrow infiltrate establishes the diagnosis of CLL, regardless of the number of circulating lymphocytes or existing lymph node involvement. CLL cells are positive for B-cell-associated antigens such as CD19, CD20, CD24, and human leukocyte antigen DR. In addition, leukemic cells of the great majority of patients express CD5, CD23, and CD200. Each clone of leukemia cells is restricted to expression of either kappa or lambda immunoglobulin light chains. A panel of CD19, CD5, CD20, CD23, kappa and lambda is usually sufficient to establish the diagnosis. The diagnosis of CLL is greatly aided by use of a scoring system. A score of 4 or more points is confirmatory of CLL. The levels of surface immunoglobulin, CD20 and CD79B are characteristically low compared to those found on normal B cells. In some cases, biclonal CLL expressing both light chains or different levels of expression of other immunophenotypic antigens is also seen. Immunophenotyping by flow cytometry in a CLL patient using CD19, CD5 and CD23 monoclonal antibodies. There is a major population of CD19, CD5, CD23 positive CLL cells and a minor population of CD19 negative CD5 positive normal T cells. Characteristic immunophenotype of chronic B-cell leukemias and B-cell lymphomas is shown in the table. The total leukocyte count can vary between 5,000 to 10,000 and more than 100,000 per microliter. Very high values at presentation are not frequent, with the most prevalent cases having a count between 30,000 and 50,000 per microliter. In the early stages of the disease, the peripheral blood abnormality is confined to the lymphocytes. The differential count shows a marked relative and absolute lymphocytosis. In CLL, both the lymphocyte count and its doubling time, greater or less than a year, of prognostic significance. It is important, when performing a manual differential count, to count smudge cells with lymphocytes, otherwise the absolute lymphocyte count will be wrong and estimates of the doubling time will be inaccurate. Neutrophils are reduced as a percentage, however, their absolute count is usually normal, or in some cases moderately increased. Neutropenia is uncommon at presentation unless cytotoxic therapy has been administered. Later in the disease course there is a normocytic nomochromic anemia and thrombocytopenia. Their presence is an important unfavorable feature which correlates with the extent of the disease. Hemoglobin is normal in early stages to moderate or severely depressed values in advanced CLL. The circulating leukemic cells are typically small, mature-appearing, round or slightly oval, with a high nucleocytoplasmic ratio. The cytoplasm is usually scanty, weakly basophilic, and with a regular outline that forms a thin rim around almost the entire nucleus. The nucleus is usually round and eccentric with a regular outline. The appearance of the chromatin is very characteristic, being markedly condensed but in a heterogeneous manner so that there are dark clumps or blocks separated by pale slits, creating a mosaic pattern. CLL cells with mosaic or soccer ball chromatin pattern. The nucleolus is absent or inconspicuous and barely detectable. Sometimes a pale area, suggesting the faint outline of a nucleolus, is visible. A minority of CLL cells may have nuclear clefts, folds, or indentation. In some CLL cells, the nuclear outline is less regular, forming several angulations, and the chromatin mass has a smoother appearance. In rare patients with CLL, the cytoplasm sometimes contains small vacuoles and occasionally granules, globular or rod-shaped inclusions or crystals, which represent immunoglobulin. The FAB group has proposed a morphologic classification of CLL consisting of two major types, typical CLL and an atypical CLL category. The WHO classification of lymphoid malignancies does not divide CLL into typical and atypical categories. Up to 55% of the cells in CLL may include prolymphocytes, lymphoid cells with cleaved nuclei, or large lymphoid cells with an atypical appearance. Atypical morphology with an increased proportion of prolymphocytes is associated with worse prognosis and cytogenetic abnormalities, most often trisomy 12 and 17p deletion. Prolymphocyte is a medium-sized cell with moderately abundant and pale weakly basophilic cytoplasm, round or oval and sometimes indented nucleus, condensed non-clumped chromatin and a single large prominent nucleolus. In some CLL patients, large lymphoid cells with an atypical appearance are present. CLL lymphocytes are more fragile than normal lymphocytes, and thus the formation of smudge cells during the spreading of the blood film is common. This feature can be helpful in diagnosis but is not pathognomonic. Smudge cells may be presented as bare nuclei isolated from the broken cells, varying from well-preserved nuclei without cytoplasm to smudged nuclear materials with the arrangement of strands in a coarse network. A higher percentage of smudge cells, 30% or more of lymphocytes, has been found to correlate with reduced CD45 expression, reduced vimentin, hypermutated immunoglobulin heavy chain variable region genes, and a better prognosis. The first CLL patient for presentation is a 91-year-old man with marked leukocytosis, thrombocytopenia, mild anemia, relative and absolute lymphocytosis, and a large cluster of the lymphocytes in the white cell differential scattergram. (79% atypical lymphocytes were counted in the manual leukocyte differential count. Low-power peripheral blood smear evaluation showed many smudge cells and numerous small lymphocytes with rounded nuclei, compact and homogeneous chromatin, and scanty cytoplasm. High-power peripheral blood smear observation showing small lymphocytes with scanty and pale blue cytoplasm, round and eccentric nuclei, with chromatin condensed into large dark clumps. At high-power observation, the mosaic structure of the nuclei is more evident. This appearance is very characteristic of the CLL lymphocytes. Peripheral blood smear showing a small lymphocyte and a larger cell with more plentiful cytoplasm, less compact chromatin, and a pale area suggesting a nucleolus. Flow cytometry immunophenotyping revealed that the surface marker's expression pattern corresponds to CLL. The second CLL patient is a 78-year-old woman with leukocytosis and lymphocytosis. Peripheral blood smear examination and manual leukocyte differential count showed 68% atypical lymphocytes and few smudge cells. The patient's peripheral blood smear showing small lymphocytes with characteristic morphology of CLL cells. The patient's peripheral blood smear showing pro-lymphocytes and lymphoid cells with atypical appearance. The patient's immunophenotyping profile corresponds to CLL expression pattern. Another CLL patient is an 81-year-old man with mild leukocytosis and relative and absolute lymphocytosis. Small and large lymphoid cells, 70% atypical lymphocytes, and smudge cells were observed in the patient's peripheral blood smear examination. This patient is a case of BCLL mixed cell type, with heterogeneity of size and morphology of lymphoid cells, consist of lymphocytes with the monomorphic morphology of CLL, typical prolymphocytes, and large cells with plentiful cytoplasm, nucleolus and open palar chromatin. Patients with CLL have a significant incidence of autoimmune disorders affecting hemopoietic lineages. Autoimmune hemolytic anemia, with a frequency of 7 to 10% of CLL cases, is particularly a feature of advanced stage disease. The blood film shows spherocytes and polychromatic macrocytes. Autoimmune thrombocytopenia is associated more with earlier stages of the disease. The blood count and film show reduction of platelet numbers out of proportion to the degree of anemia. Occasional patients develop Evans syndrome, autoimmune hemolytic anemia plus autoimmune thrombocytopenia. Pure red cell aplasia is a less recognized association of CLL, which may be underreported. It may be autoimmune in origin or the result of a chronic parvovirus B19 infection. It usually presents with anemia of sudden onset. Severe anemia and reticulocytopenia with preservation of a normal platelet count suggest this diagnosis. Autoimmune neutropenia occurs in about 1% of patients, and pure white cell aplasia is a rare occurrence. The last CLL case is a 76-year-old woman associated with cold agglutinin. The peripheral blood smear showed marked red blood cell agglutination, many smudge cells, 11% prolymphocytes, and small lymphocytes with characteristic morphology of CLL cells. Cold agglutinin disease is a rare cold autoimmune hemolytic anemia. In the context of CLL, cold agglutinin disease can occur as a paraneoplastic phenomenon, in which malignant B cells produce cold agglutinins. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.